I thank Cybersight, Andy, and Lawrence for giving this opportunity to talk on this forum. I am Dr. Hegde Shivaramaiah. I am a vitreoretinal and uveitis consultant in the Prasad Netralaya in Udupi and Bangalore. So I'll be talking on the basics of diabetic retinopathy. So where I'll be talking on the lasers in diabetic retinopathy. Nowadays, after the invent of anti-VEGF, we have to give both lasers and anti-VEGF to the patients, and I'll be taking how to do lasers in diabetic retinopathy. My objectives of the talk will be to tell what is laser and the mechanism in the retinal laser, what all investigations to be done before doing a laser, and when is the indication for the laser, and what are the laser machines available and how you set the laser machine, and what are the clinical trials present in the cases of lasers in diabetic retinopathy. And I'll just try to clear the common doubts which are there for doing the lasers. So as everybody knows, diabetes in all over the world is increasing. More than one person in 11 people will be having the diabetes nowadays. If you consider all the diabetics in the world, it will be the third populated country in the world. More than 93 million. That means 1 in 3 living of diabetes will be having some or the other type of diabetic retinopathy. It may be sight threatening, may not be, but they have diabetic retinopathy, and it's important now to look into this problem very seriously. Now coming to the laser. The laser is an acronym for light amplification stimulated emission of radiation. It works on the central concept of converting electrical energy into high electrical density beam through the stimulation and amplification of the light. Here you can able to see in this image, where the pumping source will come into the within a cavity, and there the atoms will get excited and they don't go back. So the multiple repetition of these excited atoms will excite the other atoms, and these, when you leave through the small opening, it will give a laser output. This laser output has multiple properties which doesn't normal light doesn't have. Like it has a monochromatism where it emits only one wavelength of light. It has a coherence, means all the lights are on the same phase. They are polarized and they go in only one direction. And when it goes in a one direction in a small area, it has a high energy. So various wavelength and various lasers we use nowadays. The most commonly for the retina, we use 810 nanometer diode previously, and now it is most of the times it is replaced by double frequency Nd:YAG laser, which is 532 nanometer. The 1064 Nd:YAG laser we use for YAG capsulotomy, and the subthreshold laser we use 577 yellow laser. 193 nanometer excimer laser we use for LASIK. So how does this laser works? What is the mechanism of this laser? The laser has many effects, like it can be due to the thermal effect or the photochemical effect or the ionizing effects. The most and important what we use in the retina is this effect of photocoagulation, where when the pressure, when it gives the laser light, it will cause the increase in the temperature in the tissue, and that will cause a photocoagulation of the tissue. And another important effect is photodisruption, where the laser will cause a disruption of the tissue, especially where we use in capsulotomy. Photovaporization we use in the femtosecond LASIK, where we use for the SMILE techniques. Photoablation, as I told you, the excimer laser, what we use to in the LASIK is mainly a technique of photoablation. The main thing what we require now is a photocoagulation in the retina point of view. So how does this work? As I told you, when you put a laser light to the target tissue, it will generate the heat up to the extent where it will denaturate the protein in that area. This coagulation of the protein will make that area scarred and burnt out, this causing the surrounding area to get affected. There are like various pigments are there on the fovea, like melanin, hemoglobin, and xanthophyll, and they usually absorb certain lights, especially the blue and green range lights. So it's better for us, especially on the fovea where the xanthophylls are more, better to avoid blue laser lights. But the melanin, they go from 300 to 1300 nanometers. So peripheral retina, you can give the green laser, which works better. But to the fovea, it should be avoided. So coming to the role of lasers in diabetic retinopathy, as I told you, normally we do it in a four conditions. The first and foremost, the most important what we do is pan-retinal photocoagulation. And the second thing is the grid laser, and we do focal laser and the subthreshold laser. We use lasers other than diabetic retinopathy also, like in vein occlusions, like in vasculitis, CSR. There also we use, but it became most important in diabetic retinopathy. So coming to the first question, what I need to ask to the attendees, when do we do pan-retinal photocoagulation in diabetic retinopathy? Is it in mild NPDR, moderate NPDR, DME, or PDR? You can, the poll has been coming to your screen. You can vote for the answer. Yeah. So most of them has given the very good answer, saying this is a proliferative diabetic retinopathy where we do. Yes, I wanted to I want to change after this lecture. Those who have answered mild and moderate NPDR, why we won't do the laser in those conditions. So the answer is proliferative diabetic retinopathy. Correct. So we have to do a laser in the cases of where the new blood vessel has been developed. So the diabetic retinopathy goes in various stages, like mild, moderate, severe, very severe. And when the new blood vessel develops, we say it as proliferative diabetic retinopathy. So this laser, when I tell you the mechanism, then you'll understand why do it in PDR cases. So there are like various stages which are there, and we do diabetic retinopathy, especially in the case of PDR. And there are certain conditions like in a severe NPDR conditions where you feel the patient may not come for a follow-up, or there can be a type 1 diabetes and is very uncontrolled diabetes, and the other eye has a proliferative diabetic retinopathy, or he's lost his eyes, and his HbA1c level, what we do to see how his blood sugars is more than 9 or 9.5. That time we do the lasers for the severe NPDR, or else the other mild and moderate doesn't require any laser. So the main indications in pan-retinal photocoagulations are the high-risk PDRs, where they have developed a very large NVEs and it can bleed anytime, which can lead to vision loss. It can be in a very severe NPDR with uncontrolled sugars. It can be the other condition where the other eye has a PDR, and the other important condition is ocular ischemic syndrome, where the blood supply to the eyes are decreased, which can lead to relative hypoxia and the development of NVEs. And we do the laser if possible preoperatively before doing a vitrectomy for tractional retinal detachments. So this will decrease the neovascular effect or the angular looking effect of this NVEs, and which help us to decrease the bleeding during the surgery. So what is this principle of the PRP? So these laser marks, when you give, it will go and damage the retinal cells. There, due to the photocoagulation effect, these peripheral retinal cells are damaged. This decreases the overall retinal oxygen demand and the level of retinal hypoxia. This further decreases because of the relative, we are shifting from the relative hypoxia to the anoxia level. There will be down regulation of the angiogenic factors and the VEGF production. This helps to increase the oxygen perfusion to the remaining viable retina in the posterior pole. So normally, if this is the retinal fundus, we usually do the laser in this all over the area, and we should be avoiding the optic disc and the macula, and usually we say 1 disc diameter away. 1 disc diameter away nasally we have to do the laser, and in the temporal side at least 2 to 3 disc diameters away from the macula we have to do the laser. And we usually cover it in multiple sittings, and we try to do the laser up to the extent possible, or at least up to the equator it becomes important. Now coming to the grid laser. The grid laser we usually do in the cases of macular edema, which is not resolving. Nowadays, after the advent of this intravitreal injections and steroids, the need for grid laser and the focal laser has decreased, but there are certain conditions where the macular edema is not resolving or is very much still the patient requires many injections. That time we do the grid laser, and they mainly work by photoreceptor destruction, and this destruction will close the retinal capillary and endothelial cells in that area, and it will enhance the outer blood retinal barrier, which helps to decrease the macular edema. So normally we do like a various type of grid lasers like modified grid laser or normal grid laser, and we do just outside the fovea, like in 3 to 4 rows we can give, and which will decrease the macular edema. And it takes some time. It don't decrease immediately. It will take at least 6 weeks to 2 months to act. Similarly, we do focal laser in the conditions where the leakage or the diabetic macular edema is due to microaneurysms, where doing hitting directly to the leaking aneurysm will close it through thrombosis or through heat-induced contraction. And once these microaneurysms are closed, similarly the fluid uh, extrusion will also decrease and the macular edema will decrease. So this is the photograph where you can able to see if you are seeing any leaking aneurysm, you can directly hit on the leaking microaneurysms. This comes to my second question. So what test is important for us to identify, quantify, and prognosticate macular edema? Will you do B scan, fluorescent angiography, optical coherence tomography, or fundus autofluorescence? I think the question has been come to you. So these are all tests usually we do in various conditions, but which test is important for us nowadays to prognosticate macular edema? Yeah. So 81% of the people have answered very nicely saying the OCT, and everybody knows the OCT is the most non-invasive and the most commonly used most commonly used investigation nowadays to identify the macular edema. Correct. So we do B scan in a condition where you are not able to see the retina, there is an extensive vitreous hemorrhage or the extensive cataract to look for tractional retinal detachments. Fluorescent angiography we do to look for NVE and autofluorescence in various other conditions, especially like dystrophy and all we do. But OCT helps us to quantify and identify many things. This is the image where you can able to see the presence of macular edema. And whenever we see the OCT, we should see various things, not only whether the fluid is there or not. So there are like certain biomarkers which will help us to say the prognosis to the patient. Like what type of fluid is it? Is it an interretinal fluid or a subretinal fluid? Is there any cystic space or a degenerative space? How is the ISOS junction? If there's a disruption of the ISOS junction, the prognosis is not good. Whether there is a disrupted interretinal layers or any outer retinal tubules. So all these things will help us to prognosticate to the patient and to the show to the patient. And whether we can also see whether our treatment is working or not after doing the repeated scans. So we do also the other investigations. What we do is the fundus photo. This is a nice photograph. What it will come, and you can show to the patient, and you can explain to the patient. Or else some patients may come with 6x6 vision, and they say, "I don't have any issues. Why you are doing this all this treatment?" So this fundus photo is the most important investigation to explain to the patient and for you also to see. And if you have any doubt of showing any neovascularization or anything, fundus fluorescent angiography, which is the gold standard, we can able to see the presence of neovascularization and leakage. And also we can able to see how much is the capillary non-perfusion areas, especially in the case of severe NPDR, whether we have to do the lasers or not. And if it is more than 10 areas, that time we may plan to do laser. And the recent technique which has been come is called OCT angiography. And this without injecting the dye, we can able to take the photograph. And this photograph nicely depicts the presence of certain multiple neovascularization. Here is the one, here is the one, and here is the large neovascularization which is present. And it will also show how much is the retinal perfusion or the capillary perfusion. Underlying this blackish areas, you can see there is a lot of capillary non-perfusion. And this especially is helpful in the patients who has chronic kidney disease, creatinine more than 4 or 5, or in the patients of allergy to the iodine, where we can't do the fluorescent angiography. We can do this and we can identify the neovascularization. So now after discussing the investigations, let me come to the PRP technique, which is the most important part. And I always say before doing a PRP, you should be always knowing about the machine. If you don't know which machine you are working on, what settings you are keeping on, it will become difficult for it to you. It's just like driving your car. If you know the settings of the car, you can drive much comfortable similarly. So there are mainly different delivery systems which are present. So normally and nowadays, I do most commonly the slit lamp system using the contact lens. And another what we can do is a laser indirect ophthalmoscope, and for especially nowadays we do for ROP. And if there's a dense cataract and all, we try to do in laser indirect ophthalmoscope. And we also do the laser in a condition of intraoperatively by using the endo laser. So you should be knowing about your machines and settings. The most important thing when you're doing the laser are certain parameters you should be knowing in the machine. The first important parameter is the spot size. So this spot size is the size of the spot which are going to give the laser, and it will be usually starts from 50 microns up to the 800 microns. And depending on whether you're doing a PRP or the focal laser, you have to set your spot size. And duration of the laser is the what duration you are giving the laser. It also starts from 50 milliseconds. It can go up to 1000 milliseconds depending on your machine. And also, as we are giving multiple spots, there will be the settings to see how much interval we need to keep between the two spots. It also can start from 100 milliseconds to the continuous part, or you can also keep it like 300, 500 up to 1000. Power, we usually adjust the power starting from 100 to have the grayish white burns. There will be another option called beam intensity, where we are focusing light also we can increase depending on the clarity of the visibility part of it. And the patient should be kept proper head support should be there, and patient should be sitting comfortably where he can cooperate for you, or he'll be sleeping properly so that you are not disturbed while doing the laser. And the light alignment is also important, especially while doing the PRP. We use a wide angle laser, and it has a while doing a wide angle laser, always it should not be non-coaxial. It should be a non-coaxial. You should not keep it straight. It should not be coaxial so that the clarity of the vision will improve. But similarly, for the focal laser and grid laser, when you're using the grid laser lens, the both the light and the visibility should be coaxial. So this is the laser machine what I use. And here what I'm showing is the laser settings. So this is the first part is the duration part of it, which I kept 50 millisecond. And the second part is the interval between the spots. This is the power where I have kept. And this is a knob to increase the power and decrease the power. Here the lower edge one is the aiming beam intensity. And in the machine only there is a spot size. So we start from 100 to 200. And here is a magnification of the slit lamp. So I usually keep 8x part of it for doing the PRP, and for doing the focal laser, I go for the 12x. It's depending on the individuality and on the machine, whichever you're comfortable, you can keep with. The lenses now. So there are mainly two type of lenses, the indirect and direct lenses. The direct lens has a very good visibility, having the upright visibility, but the problem is the periphery looking will be difficult. That usually a Goldman contact lens. Nowadays, most commonly we use indirect lens like Mainstar and Vogue, where the image is inverted as you see in the IDO. And the advantage is you have a very wide field of view in a one view up to 160 degrees also we can able to see. So this is my third question. So what is the magnification factor of the Mainstar PRP lens? Is it 1x, 1.96x, or zero 0.8 and 3x? The magnification factor is the most important part you should be knowing, because whatever the spot size you keep, it will get magnified in the retina to a certain extent what has been mentioned. Yeah. So 40% of the people has told it's 1.96. Yes, it is 1.96. That means almost double the laser spot which has been come. And 27% has told it's a 3x. Usually there are certain lenses which may give up to 2 lens, but 3x usually nowadays we won't use that. So the answer for the Mainstar PRP lens is 1.96x, is almost a double part of it. So as I told you, this becomes important because when the light source goes into the retina, the image will double. The light power will double. So here there are the certain lens what I said. The more commonly what I use is the Mainstar PRP 165 lens, which is 1.96x magnification, and it gives me a field of view of 165 degrees. And for the focal laser, I use macular or focal grid lens, which decreases the magnification to the 0.81%, and it gives the center 75 degrees only. So we have to decrease the spot size for the macular grid laser, and we have to increase the spot size for the grid laser. So now knowing about the lens and the laser machine, how will you prepare the patient? So a fully informed consent to be taken before doing the laser, saying what is the advantage, what is the disadvantage, and complications can happen. We try to possible to keep fully dilated pupil so that the visibility for the periphery will be better. We'll be applying the topical anesthesia. If the patient is not comfortable or he is very much moving his eyes, you can try giving the block uh, peribulbar anesthesia also. And patient should be comfortably sitting in the sit lamp, or it's better to in the lying down position in indirect laser. And what usually I say when I'm doing the left eye, I will tell them from the right eye to look towards my ear so that they can fix it from the other eye. Or if I'm doing upside or downside, similarly, I will tell them to fix it from the opposite eye. This is the sample consent form which should be taken from the patient before doing the laser. And laser settings, ideally, they say we have to keep the pulse duration of 100 to 200 milliseconds with a spot size of 100 to 500 microns and a power from 100 to 750 milliwatts. But my settings, I usually keep pulse duration of 50 milliseconds, laser spot diameter of 100 micrometers, then the power starts from 100 microwatt. So from where I'll get a grayish white one, I keep it there. And I usually apply 1000 to 200, 2000 medium intensity burns in the peripheral retina. And I do it in the multiple settings of 2 to 3 settings. You can see I have decreased the spot size and also the duration. The duration once you decrease, the patient will have very less pain and the patient will be comfortable while doing the laser. And it has a better penetration of the laser also. But only disadvantage is you require more number of spots to do the laser. It's just like you're doing the nowadays the latest technique of Pascal where they kept 20 millisecond duration. Similarly, I kept 50 millisecond duration. I feel the patient is much happier, comfortable while doing the laser. So how do we apply the laser? So normally, whenever we start doing the laser, we start from the inferior part of it, so that if the vitreous hemorrhage which is there, so it should not, it will slightly drop down after 1 week or part of it. So if we are having the visibility, we start from the inferior part, then start going towards the nasal side, and we'll cover the whole area. It's better to avoid directly the laser on the fibrous tissue where it is showing here. We should not do like that. And we usually keep one disc diameter of 500 microns away from the optic disc while doing the laser. Some people, while doing on the temporal side, what you can do is like you can mark the boundary where you should not cross that and should not come towards the fovea. That is usually 2 disc diameters away from the fovea. Then you can do in the other areas. And the recent techniques like Pascal has a multi-spots, and you can start giving the multi-spot techniques also. So as I told you, start doing the laser from the inferior part. It's better to avoid the major vessels. It's better if there is a tractional detachment. Don't do on the tractional detachment. Do 1 disc diameter away from the tractional detachment and 1 disc away from the fibrous tissue. And if there is associated diabetic macular edema, start from the nasal part and also try to do some amount of the focal or grid laser. Nowadays, when we have this anti-VEGF era, I do the anti-VEGF first to decrease the macular edema, and then I do the laser only if there is no traction. If there is a traction, I never give the anti-VEGF. And after doing the laser, if there's a recurrent vitreous hemorrhage, see the retina, whether you can able to fill up the spots and try to do the fill up the spots in those areas. So ideally, if the patient is having PDR, when I start doing the laser, I try to do the laser in the inferior and infront nasal part. Then I try to cover the upper part. Then at the last, I try to do the temporal part. I divide in 2 to 3 sittings in a gap of 5 to 7 days. That will increase the patient ease and it will decrease the complications of choroidal detachment and all. If the patient, you can also do it in 2 sittings also. First do the inferior and nasal and superior nasal part, then do on the temporal part. If there is any macular edema which is there associated with it, it's always better to treat the macular edema first before doing the laser, or else the macular edema may not uh, respond later. So the next question is, when you see the neurovascular network, will you do laser directly on the vessels or not? Is it a true or false? I have already given you the answer. Part of it, certain part of it I have given already. So the neurovascular networks are the area where they are leaking. Okay. So it is the cause for your vitreous hemorrhage, or when it goes for the fibrous proliferation, it is the cause for your tractional retinal detachment. Will you do it directly like you do like a focal laser? False. Most of them have answered correctly. We all never usually hit directly on the neurovascular network, because if when you hit, there is a high chance or possibility of bleeding from the neurovascular network. And if when you do very close to the fibrovascular tissue which has a traction, it can induce the break and can go for secondary retinal detachment. Yeah. So as I told you, it's better, always better to avoid the laser burns on the optic disc, fovea, major vessels, neovascular vessels or attraction, and directly on the hemorrhages. Many people, they should be well versed with the indirect part of it while doing the laser, because sometimes if you don't know because the laser lens will show the inverted image, some people may get confused and may directly hit over the fovea side. So you should be very much careful while doing the lasers. So there is choroidal burn, how much you need to keep. Based on that, there is a classification as light, mild, moderate, and heavy. Usually, I prefer to do slightly more mild to moderate side. So this is the laser. Soon after doing the laser, you can able to see the presence of laser marks all around the area. So we do additional PRP after doing the laser. If the patient, you see still the vessels are not regressed completely, again there's a new blood vessel, there's a recurrent vitreous hemorrhage, or there's extensive skip areas. That time we try to do the augment the laser, where we do the laser between the spots. Ideally, we say there should be one spot gap between the two laser spots. Now, if there is a bleeding, we do cover it still more tighter, or else it's better always to keep one spot space between the two burns. So this is the patient where you can able to see there is again the neurovascular network which has developed, and you can able to see a tight laser has been done. But on the nasal side, I have some area to do. So try to cover that area. And also we can give anti-VEGF certain times if required. But in this case, I'm not going to give the anti-VEGF. So now coming to the diabetic macular edema and the grid laser. So in this era, anti-VEGFs and steroids are the first line of treatment. The indication of laser is when the patient has recurrent macular edema or there's extrafoveal microorganisms leak, and to decrease the number of anti-VEGF, we do the laser. And my settings for this is 50 milliseconds is a sorry, there's a small spelling mistake. It's a 50 micrometer is the spot size, and I keep a 50 millisecond duration, and the power starts from 100 milliwatts. So how to do a laser? So usually it's always better to do a fluorescent angiography and to see what type of leakage is it. Is it the leakage due to the microaneurysms, or is it diffuse capillary leak? If there's a capillary leak, we do the modified grid laser or do laser directly on the fovea. If you see this laser, what you are doing, is better not to do like this laser where you are going very close to the fovea and you are missing you are doing the laser unnecessarily to the many spots. So it's always better to do a fluorescent angiography. Here in this image, you can able to see the patient has extensive macular edema with the extensive hard exudates. So you do a fluorescent angiography and try to cover the aneurysms and try to cover in the periphery, just close to the fovea. So just discussing about how to do the lasers and part of it. What are the complications of the laser? So the most and important thing is the mild patient discomfort can be there while doing the laser. And as I told you, my way of improving it is by decreasing the duration. There will be a permanent retinal scarring. Sometimes when you do extensive laser and extensive power can cause choroidal detachments. There can be increased intraocular pressure. If you hit directly on the vessels, it can cause vitreous hemorrhage. As I told you, if you do on the detached area, sometimes it can cause a break and combined RD. They can increase the cystoid macular edema, and there will be some amount of peripheral and night vision loss. And you can certain times you can hit the fovea and the patient can have a sudden decrease in the vision. There are like certain delayed complications can happen, like if you are keeping the power more and if you hit the Bruch's membrane, and if there is a Bruch's membrane rupture, they can develop secondary neovascularization. If you're doing the extensive laser, the inflammation can cause the epiretinal membrane and fibrosis. And in the grid laser over a period of time they extend. And this extension, this atrophy can involve the fovea and can cause the decrease in the vision. The latest technique what they're doing is called subthreshold laser. So this is a micropulse technology where the laser energy delivered through repetitive short pulses. And these short pulses, what it does is it doesn't allow the retinal intraretinal temperature to go above the threshold of coagulative damage. So this helps to give the very minimum amount of energy, and then they have shown that it works to decrease the macular edema. And the another technique, what is more famous now is Pascal, where they give the 532 nanometer laser pulses in a semi-automated pattern. Like there is a grid laser or a 9 spot, 4 into 4x spot, or 2 into 2x, 9 into 9x, or in the grid variant. Like in a single shot, you can give multiple spots part of it. The advantage is it is faster, the patient have more comfort, and it has an advanced precision. The latest technique, another what they nowadays they use is Navilas technique, where you can feed the laser machine about your fundus photo and FA, and you can mark where you want the laser, and based on the pupillary movements, it will give the laser automatically. If there is a lot of media opacities like dense cataract and vitreous hemorrhage, you may not be able to do with uh, set lamp lasers. That time I prefer to do LIO. So especially while during the peripheral retinal areas or in the thick cataract, especially in the neovascular glaucoma, where the pupil won't dilate and the patient who cannot sit for a long duration. And the parameters are almost same, but I keep 100 microsieverts as a duration and I give the laser marks. And I use 532 nanometer laser only for giving the lasers. The post-op care, make the patient comfortable. Tell them after doing the laser for 2 to 3 minutes, there will be a bleaching effect and you may not able to see clearly. So I tell them to close their eyes for 2 to 3 minutes. They make them comfortable. I put topical NSAIDs to decrease slight inflammation. I won't give any steroids post-laser part of it. And I won't give any antibiotics also. Certain people can give antibiotic if you feel there is a epithelial defect part of it, if you're suspecting. And so after discussing all this, let me share you some of the clinical trials, the most common landmark trials which made the lasers popular and the latest trials part of it. So it comes to my last question. Which study first demonstrated the efficacy of PRP in proliferative diabetic retinopathy? Is it the ETDRS study? Is it the protocol S? Is it a DRS or a diabetic retinopathy study or the protocol I? The like various studies are there, and you should be knowing this history so that we'll get to know what has happened from where to where the lasers were there. Yeah, it's very interesting to see how the laser was developed in the retina part of it. Yes. 60% of people told it as ETDRS study. Yes, ETDRS gave us when to do the laser and when to do the diabetic retinopathy, diabetic macular edema laser. But the first and most important, which helped us to say the efficacy of PRP is diabetic retinopathy study. So let me go through them. So it's a randomized prospective clinical trial where they did photocoagulation to the one eye with clear media and advanced NPDR or PDR in the both eyes. And their primary outcome was to see how much is the severe vision loss, which has been defined as less than 5 by 200. And they demonstrated 50% or greater reduction in the rate of severe vision loss was noted whom you did the PRP compared to the untreated control eyes. So they recommended to do the prompt PRP of the eyes in very high risk PDRs. The ETDRS study, they also tried to look evaluating whether the photocoagulation works in PDR and the diabetic macular edema, and also they looked whether the aspirin helps or not. And they defined a criteria for diabetic macular edema called as clinically significant macular edema, where you are going to do the grid laser. And the primary outcome was to see how much is the moderate vision loss. So as I told you, it has been they have defined clinically significant macular edema where they want to do the grid laser. Like if the retinal edema is located within 500 microns of the center of the macula, if the hard exudates are there within the 500 microns of the center, and thickening is present, of which one disc diameter area is part of it is there within the one disc diameter of the center of the macula. It addressed mainly three issues: the efficacy of the laser for the macular edema, and they showed 50% of the greater reduction was there. But you should remember, this study has been done in the pre-anti-VEGF era and when to do an PRP. So when NPDR becomes the most severe and the high risk PDR, is better to do the PRP. And they also showed aspirin is not going to alter the rates of progression of diabetic retinopathy, or it doesn't have any influences on the visual outcomes. The next is the DSCS studies. The first study, protocol A, where they tried modified ETDRS grid laser and the macular grid laser, which strategy works for diabetic macular edema. And at the 12 month after the treatment, they saw mild macular grid technique. If you do very minimal macular grid, sometimes it can be less effective for decreasing the macular edema part of it. And then they didn't do the long-term trial because they saw it was not improving. The another study is the DSCR protocol where they shown the intravitreal triamcinolone acetonide and the focal coagulation for the diabetic macular edema. So where they have injected the patient of IVTA and they have done the laser photocoagulation like focal or grid. So they were randomized to focal photocoagulation, 1 milligram intravitreal triamcinolone or 4 milligram intravitreal triamcinolone. And when the outcome was seen after 2 years, they saw focal grid laser was more effective and lesser side effects compared to the triamcinolone. The most important side effects of triamcinolone is the progression of the cataract and the increase in the glaucoma. And these two has decreased the vision compared to the grid laser. The next protocol, DSCR, where they shown you the development of uh, whether you want to do it in one sitting or the four sitting, and whether if you do in a single sitting, whether the macular edema will worsen or not. So they showed the macular edema is not going to worsen if you do it in one sitting also. So if the patient is having like more than not a high risk PDR or a severe NPDR, you can try to give slightly lesser burns in a one sitting to decrease the to get converted into PDR. The next protocol where they shown you the course of response to the focal grid laser for diabetic macular edema. This was also a prospective study where they did a focal grid laser which is with a central involving DME. And they saw there is a definite improvement in the or reduction in the diabetic macular edema, but not completely. So this protocol where they saw, uh, this is the recent protocols where the injection has come. So here they saw whether the aflibercept versus laser photocoagulation or observation in the DME, which is better. And in that, if you see, there was no significant difference in the vision loss at 2 years if you are managed with the aflibercept or with the laser photocoagulation, or if you give observation. So it's better to give an injection if possible. So next is the clarity study where they are shown the role of PRP in doing in the case of in the case of proliferative diabetic retinopathy study. So this is also a prospective study where they have recruited 232 participants and they saw which is the better, whether the injection is better or the laser is better. And what they have seen, the patients with proliferative diabetic retinopathy who were treated with intravitreal aflibercept had an improved outcome at 1 year compared to those treated with standard PRP care. You should always remember while doing these studies, the patients will be coming regularly and they'll be having a regular follow-up. And if you see there, the patient required multiple injections. It's not one or two injections what they have received. They have received more than 4 or 5 injections over a period of 4 to 5 months. And here in this becomes a problem where if you don't have the proper follow-up, it's difficult to do this only injections for the case of PDR. The another trial where they showed the ranibizumab plus prompt or deferred laser versus triamcinolone plus prompt laser for the DME, and In this case, if you see, if you do the laser followed by prompt or if you defer the laser also, it doesn't have more difference if you do the laser or if you don't do the laser. But if you give the triamcinolone, initially the vision acuity will be better, but there is some risk of development of intraocular pressure elevation and is the cataract if the cataract is not removed. The protocol I, which shows the study was done to look for intravitreal ranibizumab for diabetic macular edema with prompt versus deferred laser. Here, they have done for the 1 year and the 5 year studies. And the 5 year studies, when they did, they show the focal or a grid laser treatment at the initiation of the intravitreal ranibizumab is no better than deferring the laser in the more than 6 weeks. So the studies, what they show, no need to do the laser as early as possible. The anti-VEGF only will help now. But if there's a recurrence, if the patient is not able to come regularly, it's better to do the laser. Because if you do a laser, what they've shown is the decrease in the vision loss is very less, and the vision gain, or what I can say is the maintaining vision will be better if you do the laser along with the injection. This is the protocol S where they've shown the pan-retinal photocoagulation versus ranibizumab injection for PDR, and at the rate of 2 years, they told injecting only anti-VEGF was a non-inferior to the PRP treatment for 2 years. But you should always understand when to inject an anti-VEGF. So in the case of PDR, if you see there is extensive proliferative diabetic retinopathy with a fibrous traction, or there's a fibrous tissue which is there, you should never inject an anti-VEGF injection, which can lead to tractional or combined retinal detachment. So the another for ranibizumab monotherapy versus combined laser, they also showed the doing the monotherapy is better initially, and if a patient is not able to come regularly, better to do with the combined treatment. So after finishing the clinical trials, I'll just go through some silly, they're not so silly, but the more common doubts which the doctor has before doing the laser or when to start the laser. So the first question they may think of is there, if there is a PDR and there is no traction associated with diabetic macular edema, when shall I start doing the laser? As I told you, the first and foremost important is to decrease the macular edema before doing the laser. I prefer to give anti-VEGF or steroids, then start doing the laser PRPs. If there is a traction, that time I give steroids. If there is no traction, I give anti-VEGF. Or if the patient is not affordable, what I do, I start the first sitting of laser and I do the grid laser to the diabetic macular edema. And if there is a PDR with a traction associated with DME, so when you start PRP, so as I told you, I avoid anti-VEGF, I give Tricot or Ozurdex followed by pan-retinal photocoagulation. Is it necessary to do PRP before going for vitrectomy for TRD? Not necessarily. So the advantage of doing the PRP, if you are having the space, clear area where you can do the laser, it will help to decrease the vascularity of the new blood vessels which are there. And going inside, it will be very easy to do a vitrectomy, and because the chances of bleeding will decrease. And it also saves your time for doing the PRP in the intraoperatively. Is there a PDR? If there is a PDR with dense cataract, so when will you do PRP? If you are not able to do a laser also with an indirect ophthalmoscope, or if you don't have the option of indirect ophthalmoscope, so what I do if there is no traction, or I do is I get a cataract surgery done with the anti-VEGF. The anti-VEGF acts as a two things. One thing is to decrease the macular edema, and the second thing it will decrease the neovascularization. And after 2 weeks, I start doing the cataract surgery, so following phaco, where the wound would have been healed, and I can able to do the pan-retinal photocoagulation. Till what extent of the periphery we need to do the laser? It's better to try to possible as extent as possible, but at least up to the equator is becomes most important. In the case of DME, when to do a focal laser in the era of anti-VEGF steroids? Yes, for the DME, the anti-VEGF steroids have almost replaced your grid laser. My numbers of grid lasers have drastically decreased, but somewhere if there is a non-resolving macular edema, if there is extensive subretinal hard exudates, if there is a leaking from the microaneurysms which are extrafoveal, and if the patient is not affordable for the multiple injections, that time I go for the grid laser or the focal laser, depending on the leakage, what it is there. I will do the FA, then I will plan for the laser. When you go for a vitrectomy, so there are like certain indications where extensive vitreous hemorrhage where you can't do the laser, or if the patient has a macular tractional retinal detachment, or there's a combined retinal detachment, extensive premacular fibrosis, or neovascular glaucoma, or recalcitrant DME. Even after multiple injection, grid laser is not improving. We can give a trial of vitrectomy, and we can try to do ILM peel and try for the diabetic macular edema to resolve. To summarize, lasers in diabetic retinopathy is the most important, and it's the most important skill I think all the medical retina persons should develop. It depends on your machine. You should be knowing the machine very properly, which machine you are using and what settings to be used. We do PRP in the cases of PDR. Avoid hitting directly on the fovea or on the neovascular vessels. We do grid laser or the focal laser in the case of diabetic macular edema. We do slit lamp delivery is preferred, in my opinion, nowadays, where the patient and you are comfortable doing the laser. It helps to prevent the severe vision loss in the diabetic retinopathy. Even if you feel the patient has developed low risk PDR or the patient is having severe NPDR and the patient you feel is not going to come back regularly, the sugars are not under control. I keep a cutout of HbA1c of less than more than 9 or 9.5, and if you're not able to come in 2 months, I usually do of the laser. And combination of intravitreal medications and the laser helps to achieve the optical visual outcomes. Thank you. I thank Cybersat for giving this opportunity to talk on this. So let me take on certain questions and answers right now. Yeah. So yes, the first question what they have asked is in the center that don't have a OCT or a fundus camera, how can we quantify and prognostic the macular edema? The first and most important thing when you're seeing the fundus using the IDO has the best part of seeing in the IDO clinically is it will give you the depth perception. We can't quantify the macular edema more clearly, but we can say how much is the elevation of the macular edema is there or not. So which help us to know whether we need to do the injections or not. And the second thing, see the amount of hard exudates which are there. If there is a succinate-like picture or extensive hard exudates, we are very close to the fovea, which has been described clinically as a CSME, go for the grid laser. What do you think the Navilas laser? Do you have experience with it? I have is not much experience. I've done hardly for only few lasers in the Navilas. So I feel still our conventional laser is much better than the Navilas laser. It gives the better, you have to mark it very clearly and its movements are good. But the number of spots and the burn intensity is not, I'm not happy with compared to the single spot laser. Can you do laser in 90D without the contact? Can you do laser using 90D without contact to the cornea? Doing with a 90D, we can do, but it's like a Goldman lens what you're using. But it's a very small area which is there, and it's very difficult. Your hands won't be not be stable because you have to keep it very tightly. There is non-contact part of it, and you'll be moving it. So I better advise not to try also. Can you do laser 90D without contact? The same question. So after doing the grid laser and macular edema, is a vision loss? So normally, no. The has a multiple studies has shown there is the betterment or the vision loss is less than 50% after doing the grid laser. So when you are doing the grid laser, you should always make sure you are not hitting the fovea. There should be at least 350 microns away. You should not come towards the foveal avascular zone and try to do the grid laser. Like depending on the amount of edema, where is the edema? Nowadays we do modified grid lasers, and you do in the local area and make sure your spot size are less, because if after a certain period of years the spots can increase in size and that may decrease the vision in the case of uh, grid laser. How many sessions do you do the laser per eye and what time difference between the sessions? So I usually do it in 3 sittings most of the times. If there is a vitreous hemorrhage, I do the fourth sitting also if required once the vitreous hemorrhage resolves. And I usually keep the time difference of 5 to 7 days between the session. I do both eyes together in the same sitting so that the lasers can be done. What would you do if a patient has moderate NPDR, enlarged FAZ on OCT angio, vision 18, and CSADME? Yes. So this patient has told moderate NPDR and enlarged FAZ is normally the OCT angio. The clinical initial picture is the enlarged FAZ in the OCT angio. Vision is 618 and there is a CSME. I better go with the anti-VEGF first because if the patient is having a cataract or the glaucoma, anti-VEGF will help in those conditions. If the anti-VEGF is not improving or if there's a recurrent macular edema, that time I go with the grid laser or the focal laser. So what is the side effect of having confluent laser spots, little or no space between the spots? The thing is, what we are doing in the laser, we are burning the peripheral retina. So if you're doing more confluent laser spots, they will increase in the size over a period of time. And the increase in the space, the whole retina in that area is burnt out. So what happens there when there is a loss of photoreceptors? There will be a peripheral field constriction. There will be a decrease in the night vision. So it's better not to do confluent laser spots because of that reason. There will be a decrease in the peripheral vision. There will be decrease in the field of vision. How can one can get increased IOP with the retinal lasers? Yes. When you do photocoagulation, when you are doing the extensive photocoagulation, it can increase the temperature or the inflammation inside the eye. This inflammation can increase your intraocular pressure sometimes. What is your preferred option for DR, PRP or anti-VEGF injection? So the preferred option for DR, it depends on the what stage the DR is all, depends on the multiple situations actually. So what is the socioeconomic status of the patient? How is his control of the blood sugar? And what is his financial status? If there is advanced PDR, like already there is a fibrovascular proliferation, there is a tractional detachment in the extrafoveally or in the nasal part, I will do directly the laser. If there is a angry looking enemy or what you say the flat neovascularization, that time if the patient can able to come back regularly and affordable, I go with injections for 2 to 3 months initially till the regression of the new blood vessel. Then I call them 2 monthly ones. If I feel the patient is not going to come back regularly or the patient has various other issues, so what I do, I give an anti-VEGF injection when there is no traction. So that one injection helps in two things. One thing, it will decrease the neovascularization very early and it will prevent the formation of diabetic macular edema if it is not there. And then after 1 or 2 weeks, I start doing the laser. How has the advent of anti-VEGF treatment affected laser treatment in PDR? Yes, definitely it has helped us. So I give anti-VEGF as I told you. If the patient is affordable in the flat NVs, I give before doing the PDR. And if there is a recurrent vitreous hemorrhage and there is no traction, anti-VEGF helps very nicely to decrease the neovascularization. So what about PRP effect on accommodation? Yes, it will affect the accommodation to a certain part depending on the how much of PRP you have done. If you have done very tight PRPs in the periphery, that will affect your accommodation. Is there any role of alpha agonist topical drops or oral acetazolamide post-laser for the prevention of post-laser increase in IOP? The increase in IOP is very rare to happen. So usually I won't give any anti-glaucoma medications post-laser, and I won't start steroids also because the inflammation because I divide the sitting in 2 to 3 sessions, my formation of rise IOP is very less. Is ERM a contraindication for PRP? No. PRP we can do even if there is a ERM is, but the only problem is it can worsen a lot. Slightly it can worsen after doing the PRP, but you should be on the regular follow-up. While doing PRP, if the patient changes his focus, then what happens? So just the advantage in doing a slit lamp laser. If you do the laser with the intact where the eye is moving, that time you can hit on the fovea or the optic disc. But when we are doing with the slit lamp and the contact lens, You are keeping the contact lens on the patient's cornea with the visco. So the movement or the changing of the focus of the patient is very, very less. And you should be very careful and usually better not to keep the continuous laser. Keep the duration between 200 to 250 milliseconds between the interval between the two spots, which will help to decrease the inverted hit to the fovea. If 1 by 4th has retinal capillary dropout, can I give anti-VEGF? So it depends on the where the capillary dropout is there. Is it saying for diabetic macular edema or is it for the PDR? So if there's this doesn't count to give whether you want to give anti-VEGF or not. Next question. Why we use high power with endo laser? We won't We are not using very high power. Normally, we start from 150 to 200, but we should know what we are using this part of it. The laser spots what we are using with the endo laser is slightly on the larger part compared to what you do. The amount of far you are, the larger the spot will be. The amount of closer you are to the retina, the size is comparatively smaller. So you are under the fluid also in that area that may require slightly high power. It doesn't mean like you require very high power. One thing, the space between your endo laser and the fluid which is there between will decrease the power of the endo laser. That's the reason we keep slightly higher power. What are your laser PRP settings with master lens? So as I told you, my PRP settings are 50 microns per, 100 micron spot size, 50 millisecond duration, and interval between the two spots I keep it at 200, and the power I start by 100 to 110 microwatt, and till I do it until I get the grayish white laser. Which machine you do for PRP? I use Zeiss 532 Visualis for a single spot laser. Can you please send a recording that our Andy will help you for those things? It will be recorded. I think you will get it in the website. Will will the increase IOP resolve later if it happens? Yes, it will decrease, but you should be on the regular follow-up. What is the cost of the PRP? It depends on the place to place, how much you keep. So in India, it can be start from around 2,000 to 10,000, depending on the place, area where you are doing part of it. If the patient has CSME and NVE, if both resolve after anti-VEGF, do you still do PRP afterwards? As I told you, I'll see how is the patient's financial status, whether he's going to come back or not. Because if the patient, after giving the injection, if the patient didn't come for many months, and if he develops recurrent NVE, these are very bad NVEs. They proliferate very badly and they'll cause tractional retinal detachment. If the patient can able to come follow up regularly every 1 month or 2 months, I give anti-VEGF or else I do off the laser after giving the injection and once the edema is decreased. How do we do PRP in the patients with high IOP? We decrease the IOP giving the anti-glaucoma medications and we have to look why the IOP is there in the case patients of PDR. The patient already went for the neovascular glaucoma. If the patient has gone for a neovascular glaucoma, we try to see the NVI or do the gonier to see NVA. If it is there, what I do is like I inject first anti-VEGF, which will decrease your NVA and NVA very quickly, and your IOP will decrease drastically in 4 to 5 days. Then I start doing the laser. Why high number of retinal photocoagulation shots are required using the Pascal as compared to single spot? So as I told you, the spot size and the duration what you keep in the Pascal is less. It is 20 millisecond duration and the spot size is around 100. So you require more spot size. How to manage such patients with corneal opacity? So you can try using the indirect ophthalmoscope if you're not able to do with the if you're not able to do with your slit lamp laser. But if there's extensive corneal opacity, you have to do the endo laser itself. What is the most common complication of PRP? The most common complication what I've seen in my practice is a slightly patient discomfort and other than that, the slight decrease in the peripheral vision. So otherwise, we don't see a lot of other complications. If the patient won't come, they'll come with very bad TRDs. Yeah. So I thank CyberSite for giving this very nice opportunity and all the attendees and the questions were very nice. I hope this topic will be helpful for you two people to do the laser. It's just very easy to do a laser. It's just like playing a video game or driving a car. You should know the machine, you should know what you're hitting. Don't hit fovea and macula, and we can able to do clearly. Thank you.